I want to welcome everybody today. I know some people are still coming in and getting breakfast and getting settled. We're just going to go ahead and get started so that we can stay on time and stay on schedule. I appreciate you all getting up at this early morning to kick off the first day of AADE conference, and we're just overjoyed that you're here with us and spending this morning with us. Today, our program is entitled The Clinical Data the CGM Experts are Talking About Now. And I will be the moderator. My name is Christy Pospischal, and I'm the Director of Medical Science and Education at Dexcom. And for those of you that are local in the audience, I might look familiar because I'm from the great state of Texas and local here to Houston, so glad to be what I would consider home. I do want to mention that today's broadcast, today's presentation, is going to be recorded. And what you might want to know is that this recording, as well as the slides, because everybody loves slides, will be available on the Sigma website. And you can see that web address here. It is cgmonitoring.net. So you'll be able to probably give it about 3 weeks or so, and we will be able to have the entire program available for you to review at that time. So if you are just coming in and you may not have connected to Wi-Fi yet, just to let you know, if you want to connect to Wi-Fi and submit questions throughout the program, you can connect. The Wi-Fi is actually Omnipod. There's no login. You just select Omnipod. That'll connect you to the Wi-Fi. And then you can either text or go online to submit your questions. We can see the questions up here. We'll have a little bit of time at the end of the program to go over and spend some time answering the questions that you submit. So you can see, go to pollev.com/2019AADE to submit a question, or you can text 2019 AADE to 22333, okay? Now, what I want to do before I bring up our guest speaker, Dr. Grazia Aleppo, I want to tell you a little story about how Grazia came to present today. So we're going to present some new data, not even published yet. Dr. Aleppo is going to go over the Wisdom trial, and she was actually one of the PIs on that study, and she's going to present some of those findings. So we wanted to get the best of the best for this audience. However, when I asked Grazia to come, she goes, "Oh, I'd be honored to, but today is my birthday." So today, if you will, we'd like to honor Grazia by singing happy birthday to her. So,
oh my gosh,
let's sing 1, 2, 3. Happy birthday to you. Happy birthday to you. Happy birthday, dear Grazia. Happy birthday to you. And many more.
Thank you.
So she did
It's a surprise. Thank you.
She did not know that.
I didn't know that for sure.
So anyway, so today is her birthday. You're going to love her presentation. And with that, I would love to bring up Dr. Grazia Aleppo, and she is a professor of medicine and physician at Northwestern University, and I will let her get started with our presentation.
Thank you, Christy. You guys are so kind. Thank you so much. Well, first of all, this is a great honor to be here on my birthday, actually. Why? Because I love you guys. The CDEs are, for me, the backbone of any diabetes practice. And so without you, we can't exist. So forget the doctors without our personality. We can't function without a CDE. And in fact, without CDEs, we cannot do our work with technology. So please remember that you are the backbone of our practice, and that's why I'm so happy you guys are here. So I'll give you some background about seniors and make you laugh a little bit. So at the ADA, I was asked to speak against CGM. That's pretty interesting. And so this is the actual time I can speak for it, and I'm very excited about it. So we'll talk about background first. So you might not be aware, but actually you are aware of this. People are getting older with diabetes. They're surviving much longer. And so there are more than 25% of seniors over 65 years of age who have diabetes. And projected in 2045, There'll be up to 35% of people above the age of 65 who have diabetes. So the populations have become much bigger, and people are living longer, but also healthily. So we need to be aware the population is not, of older patients is becoming bigger. But the older adults with diabetes also have a lot of risk factors. High risk for hypoglycemia, medications, insulin, sulfonylureas, decreased kidney function put them at higher risk for hypoglycemia. However, they also have increased risk for hypoglycemia unawareness. And you all know that the glucagon and epinephrine effect go away as a protective effect against hypoglycemia very soon in their life with diabetes. So they rely only on cortisol for very low glucose level. But what you might not be aware of is that people with type 2 diabetes have a very great risk for hypoglycemia that is not very noticed. And they have a great fear of hypoglycemia. A paper from Dr. Polanski was published a couple of years ago. They showed that many patients with diabetes type 2 have severe fear of hypoglycemia, especially if they're taking insulin or sulfonylurea. And so when we say these patients, we see these patients who don't do so well with their diabetes, they might be afraid of doing more with the glucose or with the insulin doses because they don't want to wake up with a sugar of 30 or not wake up at all. And also, until 2017, there were no CGM coverage for Medicare, which was a great shame, and now, thankfully, this is gone. But still, you have to still fight with the insurance company to cover these tools, even today. But there was so little available, not even 2 years ago. And so now we know that we have more stuff available for these patients. Also, in the past, previous studies were not using patients above 60 years of age, or if they're using them, they're very, very few, and they always excluded hypoglycemia or severe hypoglycemia. It did not focus on hypoglycemia because what they wanted to do was show efficacy, and so use hemoglobin A1C, which we know is the gold standard for showing efficacy, or used to be. I want to make sure you guys understand, used to be is the word of the day. We're talking about used to be, no longer it is. And they did not focus on new CGM, older CGM systems, and so a bit more difficult to use, maybe not so accurate, but this was the reason why we didn't have much information on older adults. I want to make sure we make a clarification right now at the beginning of my presentation, because we're talking today about real-time CGM versus intermittent scan CGM. This is very important. Real-time CGM provides the patient passively at any given time their glucose levels and alerts them, important word to remember, alerts the patient about impending hypoglycemia. Of course, also hyperglycemia. Whereas intermittent scan CGM requires active participation of the patient to scan many times a day their tool and maybe catch the hypoglycemia when they scan it, which is not very common. And so RT-CGM is the way to go because it informs the patient at any given time of impending hypoglycemia with alerts and alarms. And so can older adults use CGM safely, and do they benefit from it? Let's find out. So I'll talk about some background study before I go into the wisdom study. This is the Diamond Senior Study. Enroll 60 years of age patients or older. It was a randomized clinical trial, 116 people. Type 1, the minority, it's important to remember, the majority was type 2 patients. We forget these patients also need to be told to go on CGM. It's a very important thought. There are 30 million people with type 2 and 1.5 with type 1. It's more of them. And so they were assigned between control versus RT-CGM. They were on MDI, and the reason why they were MDI is because only 30% of patients use an insulin pump. The great majority today still uses MDI, so we need to use the population that is more likely to benefit from CGM, which is actually the MDI. 67 years of age on average, 20-year plus of diabetes duration, and A1C baseline about 8.5%. And so in this Diamond Senior studies, they had a between group difference of reduction of A1C of 0.5%. Now, remember the JDRF trial 11 years ago now, 2008, at 0.53%. So this is the typical classical, at least reduction of A1C you'll see with CGM trials. Not only that, 97% of these patients were using CGM for more than 6 days a week. And if you remember the JDRF trial, they were not 97% at all. In fact, for the children and adolescents, it didn't reach significance. They were using 2 days a week. And so that is a very important thought. They were using the CGM all the time. More than 6 days per week. There also was a significant improvement in time in range. This is a new word of the day, TIR, time in range, 70 to 180 milligram per deciliter. They had 2.5 extra hours per day in range, and that is a huge, significant number. But also they decreased by 1.5 hour of time above range, above 250. This was before the new guidelines for time in range were published, so there is no 180, just above 250. Very small hypoglycemia in both groups, but look at the bottom of the slide. High CGM satisfaction. I'll read this through just quickly. Our TCGM makes me feel safe, knowing that I will be warned about my low glucose before it happens. If you speak with your patients, I know you guys do this every day, they say, I don't want to be low. I'm afraid that I'm going to be in a car accident. I don't know what I'm doing. I'm thinking I'm going to pass out. I'm not going to wake up. So that is a huge problem, especially if you're getting older. The sense of fear becomes even more so, more important because they feel even more vulnerable and they want to keep their life all together. Number two, our TCGM teaches me how eating affects my blood glucose. And that's huge because it's a behavior modificator. People see what the food might do to them and actually adjust their insulin based on that trend. And last one, I will recommend our TCGM to other people with diabetes. These are patient-derived information. On top of the diabetes, the Diamond Senior study, there was a parallel study which was for quality of life improvement. Now, it's very hard to define quality of life sort of assessment because you need to make it sort of objective. But in this very study, focused only on this, and they had significant amount in decrease of diabetes distress, which means how much having diabetes affects my life. Also, there was a significant increase in hypoglycemia confidence. What does it mean? It means that the patient were feeling confident they could deal with hypoglycemia and they would get out of hypoglycemia. And there was improvement of quality of life regardless of age, education. We need to remember that anybody can do CGM. You can have third grade or PhD, you can use CGM. You don't have to have this big mind. And there was a very high CGM satisfaction compared to previous studies. This is Chuck. Diabetes has been a series of losing battles for 20 years. CGM is giving me my first win. You can't give a price to this. It's absolutely humbling and priceless for us. Because when a patient is so comfortable, after they've dealt for 20 years with a lot of frustration, feeling bad about themselves, that is victory to me, in one word. So what I want to show here is how Diamond was set up. And why is this important? Because actually this is how you can educate your patient. It was very simple, by the way, with a very small amount of follow-up. And that's the same we did for Wisdom as well. And so I divide this slide in 4 portions. Number 1, wear your Dexcom as much as possible. Patients were told to wear the tool, okay? Look at it. Look at it. The more you look at it, the better you do. And calibrate was important for G5. In the future, this will go away with G6, but for now, we had to teach the patient how to calibrate correctly. Number 2, this was something about how to interact very well with it. So higher lows will come in, look at them, pay attention, but don't overdo things. Just share the result, don't keep it for yourself, and that's something that people need to do better and learn to do that. But also look at it as you are your own provider, your own physician, your own clinician. What did I do that could have done better? And the next day when you eat the same food, maybe take your insulin earlier, just look at it. Number 3, review with your clinician. If you don't review, it's useless. The clinician needs to see what's happening so they can give you some advice and actually learn from what you've been doing with your CGM. And have a plan on how to approach low glucose. And number 4, the advance. Use the Dexcom to the trends to improve your glucose. Use the trend arrows, and we'll talk about that in a moment. And try to avoid insulin stacking, which is a big issue when people at first look at CGM. They see a lot of data and say, ooh, am I so high? And I said to them, you always were high. You just didn't know about it. So now you know, don't overdo it, right? You guys are laughing because you know what I'm talking about. So Wisdom. Wireless innovation for seniors with diabetes mellitus, the most ambitious thing we've done in a long time. And I'll tell you why in a minute. So for the first time ever, this study was not about A1C. It wasn't even in our mind. It was about, can we prove we can help people with diabetes in the older age? And this was basically a follow-up study to what we did with T1D Exchange many years before about hypoglycemia in older adults. And they made us say, we need to do something about these patients. So it's a randomized clinical trial, 6 months duration. The screening phase was done with masked CGM, and I'll tell you why it was so important. 200 patients, 1-to-1 to either G5 or BGM with every so many weeks masked blinded CGM. The primary objective was determine if CGM can reduce hypoglycemia. That's ambitious and pretty gutsy because it could have been a fiasco or a success, right? You don't know older people. We were gutsy. When we were designing the study, and I was privileged to do that with them, it was like, what are we going to do with this study? Can we actually make it? We were confident, though. I'll show you in a moment. So the eligibility criteria were as follows. Above 60 years of age, type 1 patients, A1C less than 10. Why so high? Because you know very well that the amount of hypoglycemia is regardless of A1C. You don't think that high A1C is less hypoglycemia. It doesn't matter. There's plenty of data they show in the literature. You can have just as much hypoglycemia with A1C of 7 and A1C of 10, especially in older adults. And then they couldn't use CGM for at least 3 months, so they were able to just learn from scratch and no diagnosis of dementia. Now, a little comment on this dementia issue. To get a diagnosis, you have to be pretty far advanced. So we might have some patients, we knew that, who had some decline in cognition. We were able to actually overcome those with training. So what about the blinded CGM? We wanted to make sure these patients were safe, but not too severe hypoglycemia because they could have gone to the BGM group. So ethically, we couldn't get everybody with sugar in the 30 all the time. And so if they have more than 10%, it's about 2 hours a day, of glucose less than 54, which is pretty low, they could not participate. Even in the blinded CGM, we had the number. So a few patients didn't pass the screen. And then if they had one severe hypoglycemic episode in the previous 6 months, they were also excluded. So I had about 2 patients who were supposed to go into the study, but they had passed out on me. So I thought, okay, you're not going, just go and get your Dexcom. And they did, and they're alive. Whew, that was interesting. So primary outcome, again, percentage of time in less than 70 milligrams per deciliter. Secondary, here's the A1C, just at the bottom, hypo and hyperglycemia, and some quality of life, and some questionnaires. And then, of course, the metrics were comparison of CGM group with the BGM, but looking at their CGM for the 8, 16, 26 weeks. Okay, baseline characteristics. I want to point out this patient had diabetes for a long time. 30 years at least. It's a long time to have diabetes. Pump use 50%. But I want to show here the one severe episode in the past 12 months. So 6 months was exclusion, but 12 months was not. In the CGM group, it just happened by randomization. They had twice as much, 19% versus 10%. So a very high risk group, in my opinion. The A1C was about 7.5, 7.6. So look at this slide very clearly, closer to me. So time less than 70 milligrams per deciliter, okay? You see a 5.1% versus 2.7 in the CGM group. I want you to look at the minutes. You go from 73 to 39. That's 50% reduction. It's huge. Less than 70. You cut in half just by being on CGM. Whether on pump or on MDI, it doesn't matter. The P was very low, less than 0.001, so highly statistically significant. And then look at this. Primary outcome, did I do skip one? Sorry. Yes. So if you look at throughout the visits, in the baseline on the left side of your screen, you see how there was similarity. But as soon as they start using CGM at 8 weeks, 16 weeks, 26 weeks, they go low less and less and less. So it's very significant because they start going less low right away, but they continued it and improved over time. It's a bit of a challenging slide. I'm going to give you a little bit of information. So what you see here on the left side on the axis is time less than 70 milligrams in percentage. The darker blue is the actual BGM group, and the green is the CGM group. If you look at the upper portion, it's 12 a.m., so midnight, 8 o'clock, and 8 p.m. Patients always have this fear of not waking up in the day. So they tend to have these bedtime snacks that drive us all crazy because then they go up in the morning. We don't know if you should give more basil, just adjust the snack. But it's a behavioral issue. Despite doing that, the people on CGM had so much less hypoglycemia than the people on BGM, much higher, especially at night. So that was a significant too, because you know how really that it's a major concerning fact for these older patients. Now, not only we did a great job with less than 70, but if you look at less than 54, which is considered now with the new guidelines, level 2 hypoglycemia, really clinically significant, even then you go from 27 minutes at baseline to 7 minutes at 6 months. Huge. You basically chopped it off from 1.9 to 0.5%. That's remarkable. So basically almost elimination of severe hypoglycemia, I should say level 2 hypoglycemia from the new guidelines. Again, same results, pump versus MDI. And then look at this. Hypoglycemic events per week, what does it mean? An hypoglycemic event less than 54 is 50 minutes duration, and then exit from it means that it's 50 minutes or more above 70. Again, from 2.6 events per week to 0.8. So big time reduction of hypoglycemia, level 2, less than 54. But this is what really shocks me. You have 1 versus 10 severe hypoglycemic event. That means that you have to be helped by someone. You can't get the juice. You don't even know what the juice is. So severe hypoglycemia is either out of it, completely passed out, or you can sit down and just somebody has to give you the juice because you can't get up and get it, right? So you look at this, 1 versus 10. You can't give a price to this. It's priceless. You cannot justify no CGM if you have this in a study. So 1 versus 10 episodes of severe hypoglycemia in the CGM group. It's huge. Remember, if you forget everything about today, you need to remember this one, because that is the most important portion. And then secondary outcomes, did we do any better? Well, let's take a look at this, right? So they started with 56% time in range and ended up with 63% time in range, so 15 hours and 7 minutes. Now, in the new guidelines of time in range that Christy is going to show you a few minutes from now, for the older adults, they should be 50% or more in time in range, so between 70 and 180. Well, in this study, they were well beyond it, 63%. Now, in people without hypoglycemia or younger adults with 70% target, these patients, older adults, diabetes for 30 years, increasing risk of hypoglycemia, were able to reach and achieve 63% time in range by using CGM, so well beyond what is recommended from the new guidelines. And time in range, above 180 and above 250 was also reduced significantly in the CGM group. So we have now achieved every possible component of the time in range group. Less than 70 was reduced, less than 54 was chopped off almost completely. Time in range was increased above the recommended range, and time above range was decreased significantly. And now we talk about one thing that goes around, the CB, coefficient of variation. We always think about, okay, so you do better, but you actually do better, and what does it mean in English for us today? Coefficient of variation tells you the index of glycemic variability. Why is this so important? We now know very well that in the literature, if you have increase in CB or glycemic variability, you have increase in eye disease, as reported very well, you get a retinopathy or macular edema, you get increase in cardiovascular events, and increase in neuropathy. So that's published, I'm not making this up. So you have to have the tightest possible amount of coefficient of variation, and in the average is supposed to be less than 36%. These guys went to 37. So that close to being ideal. But they were not trying to be ideal, just trying to avoid low blood glucose. Remember, that was the purpose of the study, and highly statistically significant. And here it is. But I get a kick out of this. So the adolescents don't want to use CGM, the adults maybe. These guys don't want to give it away. Look at this. After 6 months, they were using CGM 81%, 7 days a week. They were like, I don't want to give this away. In fact, on my cohort, only 1 patient is back on SMBG. Everybody else is on CGM. They're like, I don't want to give it away. Can I keep it? So we had to actually make sure all these patients on Medicare had the paperwork ready before they finished the study, because they wanted to go to CGM. Now, actually, it's a very moving thing. A patient told me, and she's now on CGM, but she's off the study. Had I had this CGM before, I wouldn't have to leave my job. Can you imagine the power of the statement? She was a teacher. She passed out all the time. And so she had to leave her job. And she said to me, I wish I had this 10 years ago. So you can't, it's very moving because you can't give a price to this. It's like, oh my gosh, this patient life has changed tremendously. And then I just love this slide. So you think people don't trust CGM, forget it. These old people know what to do. They've been through the syringe you boil in the water, you swallow the syringe, the whetstone. They've been through peeing in the paper. You know what they've done. And yet, 89% bolus on sensor only. Remarkable. They know better than us. They trust these tools. Because these guys are people pretty difficult. You know, I know better. And they did it. And like, I'm fine. I know what to do. Okay. And they did. Almost 90% were dosing off a sensor. So for them, the difference between glucose and CGM is a non-existent problem. They can do the paper. If you can go to the paper and then the drops and then the meter, they can do CGM. And then one thing that was surprising, it was they did not use much share. So I asked them, So in many people in the whole cohort, they were using more the receiver, but my cohort used mostly phones because I'm in Chicago. I don't know, they were all using the phone. And so I told them, why don't you want to share? Oh, it's my diabetes, okay? So the only thing some patients shared was the hypoglycemia because they say, you know, in case I start going goofy, they know why. All right. But they want to make sure they could handle this because they felt that with this tool, they were able to help themselves in a way they never could do before. And that gives them independence. And we know people getting old, they want to be independent. And finally, so the study showed that without a doubt, you reduce hypoglycemia. For the first time, you don't even think about hemoglobin A1c. Despite that, they still did better. Improved glucose control for every possible time in range, whether low, normal, or high. There was no difference in quality of life. There was a remarkable, and there was no difference between MDI and pump, which also we knew that. There is no difference between pump and it's delivery. That is not about, the issue is not delivery, the issue is about knowledge of where you were, where you are, where you're going. And so now the last one, I'll talk about my practice. So I have a ton of patients. Yes, it looks like a geriatric clinic. So I have the 18-year-old and the 80 in the same room. So, but I have more than 150 patients with type 1 or type 2 over the age of 60, and they are on CGM. I mean, the work we do in our practice is incredible, but you know what? It's all worth it. So we use both pump and MDI, but we do in-person training. This is the trick for these patients. So when we did the wisdom, we were trying to figure out how do we train these patients well. Some of them got it right away. Some of them needed a second training. So we do in person, we do step. The first thing you do, you only turn on the low. And why is that? That's important. You need to avoid those hypoglycemia and need to tell them that they're going low. And they might have decrease in hearing, so we use the phone. You know, the iPhone, you can make this truck, big, really loud alarm, so they can get sirens, whatever you want. So they know it's actually the hypoglycemia. It's not just the 3 lines. It just can make it really loud. And so we overcame that challenge, but we left the high threshold, just left it alone, because they don't want to be bothered by being high. It makes them feel really inferior. You don't want to do that. And then eventually introduce that, and we introduce also stepped. So at the end, we did the trend arrow. So we used for the study a modified trend arrow algorithm to what is published in Journal of Endocrine Society from Dexcom, the practical approach to CGM arrows. And so that was the last thing we told them, to avoid stacking insulin, because they end up doing that too a little bit. We said, just look at that and see where your arrow is going. And they were able to master it. And so that's how we saw this significant improvement in all the parameters of glycemic trends. And so by doing this, I can tell you, you can train your older patients. You need to be patient. They actually have plenty of time because most of them are retired. So don't be in a hurry. They want to take their time, but once they get it, they got it. So don't underestimate the power of older people, because I got a big lesson on that and a great joy. These patients are happy. They all come back and say, hey, I'm looking at my CGM. Why? Because there's nothing more sweet in my mind that somebody who's lived with diabetes for 50, 60 years, you know, in the prehistory of diabetes, and now they say, I can do this, even if I'm 75. This one guy went biking in Netherlands, him and the tulips, on a CGM. He was homebound before, now he's driving again. I mean, the miracles I've seen are amazing. So use CGM, use it well in older people. And with this, I thank you so much for your attention.
Well, thank you, Dr. Aleppo, for that great presentation. And I want to remind you that if you have questions, please do. Oh, I think my slide for asking questions is, maybe I skipped it. Did I go back one? Oh, okay, it's not in there. Anyway, so if you need to ask questions, make sure to text those in or go online, and I've seen some questions been submitted already. But we're going to continue on with our presentation regarding ditching A1C for time and range. And I would say if you're not using CGM in your clinical practice, then all you really have as tools to manage your patients are A1C and finger sticks. And what we just recently saw with what Dr. Aleppo was referring to is the International Consensus Guidelines. And so I would encourage this group, this was just recently published in Diabetes Care, and I would encourage you to take a look at that publication, and we'll talk a little bit more about some of the findings in that publication as we go, but this is going to change the way you manage your patients using CGM. It's going to change the way you set goals, it's going to change the way you talk to them, and how to engage them and help to manage them over time. So this is going to be really helpful for you as educators, especially even when you go back to work on Monday. It can change the way you approach those patients. So we're in Texas. Are we ditching A1C for time and range? And I would say we're ready to give it the boot. So there it goes. So we're ditching A1C. Now the same group that brought the international consensus guidelines, they also issued a guideline or a position statement around the use of CGM and how that correlates with A1C. So AADE, the Advanced Technology and Treatment for Diabetes, issued the statement that says CGM should be used in conjunction with A1C for glycemic status assessment and insulin dose adjustments for all type 1 and type 2 patients on intensive insulin therapy if they're not at glucose targets, at their achieved glucose targets. So I would say, just in a room this size, the sheer volume, most of us with intensive insulin therapy patients in our practice are not at their glucose targets. Now what I would ask the group is, are those patients using CGM? Because that's what the guideline says. So A1C alone, let's talk a little bit about, we know the limitations of finger sticks pretty well. What are the limitations that we know about A1C? So Dr. Nick Argento says this very well. He's an adult endocrinologist with type 1 diabetes himself, and he says if you're just using A1C to manage your patients, it's like buying a house and just looking at the outside of it. You have no idea what's really going on the inside of that house or with that patient, for example. So if we have an A1C, let's just say 7%, and I'm an educator too. We sit down, 7%, we go through, that means your average blood sugar might be somewhere around 154, sometimes it's higher, sometimes it's lower. But seldom do we mention the confidence interval, which actually is pretty wide. That means your mean glucose could be anywhere from 123 to 185, which means you could be in good, fair, or poor control with an A1C of 7%. We really don't know. Now, it also, just looking at an A1C is not going to tell us or indicate the timing or the extent of hypo or hyperglycemia. We have no idea if that person's going low overnight and their basal rate's too high. We don't know if their insulin to carb ratio is too strong. We don't know if the corrections are working, if they're going low in the middle of the day because of exercise. With just an A1C of 7 or 8, we don't know that. Using CGM will give us that insight to help us to better manage that patient. It doesn't reveal glycemic variability. As Dr. Aleppo talked about, the reason we need to understand and address glycemic variability and all the problems, we know glycemic variability in and of itself increases the risk of hypoglycemia. A1C alone limits the utility, and I would say is almost useless for insulin dosing decisions. And just 2 years ago, I was working with an older gentleman, and he, a long-standing type 1 patient, 40 plus years, using finger sticks and trying to do what the physician was asking him to do, bring down his A1C, checking more often, taking corrections, and they decided to put CGM on him. And he came back, actually in 3 days, and you see this all the time, your patients come back and go, oh, I figured out what was wrong. In 3 days, having type 1 for 40 plus years, he figured out, well, I was dosing to bring that 200 blood sugar down after about 3 hours after breakfast. The problem was I didn't know I was dropping when I was doing that, so my full correction made me go low. But I figured it out and I stopped doing that. They figure it out on their own. But I would say, if you don't have CGM, you're not going to figure that out. You've got to have those arrows, you have to have those alerts and alarms for safety. Finally, A1C can be just frankly wrong, okay? In certain types of anemias, when we have hemoglobinopathies, iron deficiency, pregnancy, the World Health Organization estimates that 80% of people worldwide have some degree of iron deficiency. So our A1Cs can be just frankly wrong. And then correlation with mean glucose can vary among different races. So A1C is problematic, and especially when we look at an individual. Population metric, great. Individual level glycemic control, problematic. Now, they also looked at, if we compared A1C to CGM, how do those two things really compare with each other? So they did a study, and this was really interesting how they did this. They took 3 randomized controlled trials, and what they did is 387 adult participants with both type 1 and type 2 diabetes, and they looked at these 3 randomized controlled trials. They used CGM for 6 months in all of them, and there were benchmarks in time where the A1C had to be measured. So they looked at the last 13 weeks and measured the A1C, and they said, okay, how does this all go together? Well, guess what? There were some problems. So what they saw is when the patients were wearing CGM for that 13 weeks and their mean glucose came back anywhere from 128 to 190, they could have had a 7% A1C. And what's even more astonishing is if you're the person or the group of people that had a mean glucose of 182, you might have come back with an A1C of 9, 8, or 7. So again, we really see that A1C and this mean glucose from CGM can be completely different. So what do we do? If we're ready to give up A1C and we're going to use time and range, what are some metrics that can help us and help our patients to really understand, do we have enough data to make sure that we're estimating this time and range correctly and that we're counseling patients with the right amount of data? So what we want to aim for, and again, in the publication for you to review, number of days CGM worn should be 14 days with at least 70% of that 14 days of data captured. You should have a mean glucose. You should also have a GMI. We're going to look at GMI in the next slide and talk a little bit more about that. And glycemic variability, like Dr. Aleppo said, we should aim for less than or equal to 36. Some studies do recommend less than 33, but you want to look at that glycemic variability as well and target for less than 36. Then the other recommendations were looking at and defining the certain glucose ranges that you can see here. So the ALIGN-2 time and range defined as 70 to 180 for people with type 1 and type 2 diabetes. Level 1 and level 2 hypoglycemia, you can see the metrics there. As Dr. Aleppo mentioned, severe hypoglycemia, less than 54. That's the time below range. And then time above range, level 1 hyperglycemia greater than 180, level 2 hyperglycemia greater than 250. So this is where we're going to look at for our benchmark and refer to for the different glucose ranges. Now, I'm not going to go into every single one of these. You can look at the publication. It's written very nicely there. But what you can see here is not only do you have those time of range listed, but now you have the percent time to aim for. So if we look at time and range, what do we want to do? We want to aim for more than 70% of time with glucose between 70 to 180. We want to aim for less than 4% of the time with glucose less than 70 and less than 1% of the time with glucose less than 54. Now I know that none of us talk in percent of time, so the best way to talk to your patients about this would be 1% of time is equal to about 15 minutes. It's 14.4 if you want to do the math. But this is where we can say, look, we want to have less than 4% of the time in 70. That means less than 70. That means less than an hour should be spent with blood glucose less than 70. You can see the targets for hyperglycemia as well. So again, the goal would still be minimize and address hypoglycemia first, since that's the most dangerous, and then work on expanding that time and range. Now, GMI. GMI is featured on Clarity. We'll look at a Clarity report in just a second, but GMI is a new term called Glucose Management Indicator. And what this is let's just, for lack of a better term, call it what was formerly known as estimated A1C, okay? But we had to come up with a new name. So the new name is Glucose Management Indicator. It does not equal A1C. So you got glucose management indicator and you got a point of care A1C. How are you going to talk to the patient about this? So 3 steps. You want to explain GMI as that it would approximate the A1C likelihood based off whatever date range of glucose you're looking at. So 14 days at least is what we want to go for. It's calculated using the mean glucose over that period of time. And we all know A1C is around 120 days and how much hemoglobin is attached to that red blood cell. So GMI is simply an indication of the current state of glucose control and maybe what your A1C would be should you continue on this same path closer to 90 days. Now, how'd they come up with GMI? Well, remember those studies that I referred to, the randomized controlled trial where they looked at A1C and they had the person wearing CGM for 6 months? What they did is they plotted that against each other, drew the line, came up with an equation, and so that you don't have to do the math, Clarity, the report, I know it's kind of small, but you can see GMI is on the Clarity report. So it's estimated for you, that calculation is done for you. If you have at least 14 days of CGM data, that will be available on the Clarity report. Now, what if they don't match? They probably won't, okay? So just be ready. They're going to be off a little bit. But what we want to do is we want to talk to that patient and say, you know what? If you've had like recent episodes of hyper or hypoglycemia, maybe things aren't going the same way the last few weeks of what the data we're looking at versus your A1C. Just realize if they're sick, if they had a pump failure and had DKA, they were on steroids, that could have raised their blood sugar. Or they started a new medicine or a low-carb diet and their blood sugar's been running lower. So we can see that acute periods of time, that would cause the GMI to be different than A1C. Expect 51% of the time, the A1C and the GMI are not going to match, okay? And they'll be off by about 0.3%. And what we do know, though, is, however, if we see a discrepancy, typically that discrepancy will continue to follow that patient over time, where the GMI may be a little bit higher, the A1C might be a little bit lower, and that will probably continue over time if it's not representing that acute change, okay? So that's GMI. So let's put this all together, look at a Clarity report, and kind of tie this in a nice big bow and a nice big package using our 10 tips. So if we look at days with data, we have enough data here. 13 out of 14 days of data with 93% of that data captured, so we're in a good place to use this report. You can see the average glucose listed here for this 2-week period. That has generated a GMI for you to use. Now we're going to look at standard deviation. And you went, well, you just told me coefficient of variation. So what do you want me to do? If you want to see coefficient of variation, you can very easily go over to the AGP report in Clarity, and it'll show you the coefficient of variation. Or you can take 63 divided by 69, and 169, and that will give you the coefficient of variation as well. So you can do it either way. Time in range, so here's our metric. And to me, this is the best place that we want to go to really understand what we want to do with that patient. And at a glance, look how easy this is to start. So no severe hypoglycemia, 1% less than 70. 57% time in range, so this needs a little bit of work, and 41% in hyperglycemia. So we obviously see that highs are the problem, and if we drop down and we just look at the graph, we can see, yeah, that's a little bit high after dinner, and there might be some problems even after breakfast. Now, here comes the MA down the hallway, and they plop the clipboard on your desk, and they go, oh, here's the lab A1C, it's 6.9. And your patient goes, well, you just told me 7.4. So this is where you dig in a little bit, and you ask them, you say, okay, what's been going on the last couple weeks? Is this pretty representative of how things have been going over the last 3 months? No, I've been traveling more, I've been eating out more, I haven't been exercising as much, so I've not been as diligent as I should have been. You ask them, is that going to continue, or are we back on track now? Well, no, my job changed. Actually, I'm describing my life to you. So I think my A1C, is probably, that was great, but this is probably more representative of how things are going to be. So you make those changes, and you dig in based off that GMI and based off that time in range and based off the trend graph that you have. So it depends. Just remember, don't get anxious if that A1C and that GMI doesn't match. It's probably not going to. But here's what you do. So tying it all up, we have, with those patients, especially using the mobile device, a nice feature that I would encourage you to help your patients understand and use is when you download G5 or G6, download the Clarity app. Because what's going to happen is if those patients have that Clarity app on their phone and you've just talked to them and educated them on time and range, they're going to see it. And it's going to, by the way, they don't have to download anything. It's just going to push that email to them or push that notification to them. All you do is you go into the Clarity app and you turn on push notifications, or you turn on that email summary. That will allow that person to have the time and range or the patterns pushed to them. And by the way, if you have a person that's trying to get pregnant, and they need to set a different time and range because those are going to be different. Or if they're an older patient and we need to customize that time and range, you can customize it, and then every week that patient will receive a push notification or a full email that's going to show them how much time they're spending in range. So this is a great tool because now you just had that conversation. Now they have this push notification coming to them. Within 2 weeks, they know kind of a pattern, how things are going. Are things getting better? Am I spending more time in range? Do I need to make some adjustments? So in conclusion, we do want to encourage our insulin-requiring people with diabetes and patients with diabetes to use real-time CGM to manage their diabetes. A1C is not cutting it, especially for those patients that are on multiple daily injections. Set smart goals. The other thing I want to say, I'm not going to go into how to set smart goals. I know this group knows how to do that. But one of the things I do want to call out is one of the smart objectives is achievable target. And we're living in this gray area of A1C and time and range. And one of the things you can tell them is every 10% increase in time and range, you're going to see about a 0.5% reduction in your A1C. And people sometimes they're still going to resonate with A1C. So that could be a nice way to tell them and encourage them, this is a good target you can set for yourself. And then finally, encourage your patients to download and use that Clarity app so that they can also receive that push notification. They can see over time. We know this works very well. When we send those push notifications, we know we have an over 80% open rate. So people are looking at this. I'm not guaranteeing they're making changes, but they're opening it and they're looking at it. So encourage your patients to use that. And again, I want to thank you for your attention today. We're going to have a few minutes for questions here. And let's go ahead, and here's our question. I'll leave this slide up. And, okay, the first question, let's see. When will Dexcom G6 be available for Medicare patients? I love Dexcom, but I'm very disappointed that it's not available essentially for Medicare patients. Dexterity is a huge issue for older patients. So we definitely hear that. Publicly, we've said it should be available Q4, so keep your ear to the ground. G6 will become available for those Medicare patients very, very soon. Let's see, here's another one. And I'm going to ask Grazia to answer this one. When your GMI and your A1C don't match, is there any time you'd ever really trust the A1C over GMI? Is there any clinical reason that you should really not use GMI?
Not really. So I am more glucocentric than hemoglobin A1C centric. And so if the glucose tell me that the A1C is not right, I trust the GMI more. And the reason is, sometimes I go through a month, especially we'll work with a woman, maybe the high or lower glucose during their periods. And I can just click, with one click, I can give an understanding of 30, 60, 90 days and see, is it really matching, is it really consistent? And it really is. So if the glucose, like that graph, tells me there's so much hyperglycemia at dinner, the 6.9 is not right. It's not possible. So you need to look at the patient numbers and you will see. So I actually, and also remember, you can have younger red blood cells, older red blood cells that can really affect the A1C dramatically. You can have more affinity or less affinity for the red blood cells. So the A1C can change for a variety of reasons, but it stays always the same. You can see a patient 6 months later and it's the same sort of difference, but I look back at the glucose because I can't with the CGM. Yeah. So when I'm in doubt, like 6.1, you don't have any too low, too high. That's not real. It's not possible. That's your real CGM, your real GMI is what actually your glucose levels are at. That's my way to do it.
Okay. We had another question around, and I think they want me to go back a slide, and I think this will be the question. Let's see. I want to go to this where the bars are for all the different time and range. Can you describe to us, here it is, Grazia, can you describe to us, how would you say if there's a person with type 1 or type 2 diabetes and they fall in this category, how would you classify somebody that's older or high risk? I mean, what's the differentiation here?
So this is an important thought because if somebody has any decreased kidney function, the insulin it's cleared only by the kidneys, you need to be very attentive. If they had any cardiovascular risk, they are high risk. If they had any severe hypoglycemic before they needed somebody to help them out, they need to be treated with more gingerly. If they have diabetes for 55 years and the only thing they have is hypoglycemia, they're not going to die of kidney failure. They're going to die of hypoglycemia. So you have to be very careful. So now I switch it over. But then my patients say, I want to do better. They really want to do. They're becoming the gutsiest patient I know. They want to do well. As long as you cut down the hypo, they'll do anything you ask them to. But you need to go to the second when they start having really cognitive decline. They really don't know much. They forget to eat. There is no need to be a 120 at all because they might forget to eat and they took the insulin. So it's much, we might change their weight and they take the insulin after they're eating. So you get to look at the patient and say, can you handle this? Or maybe a spouse can help them out. So that's when I just go to the second graph and do 50% is plenty.
Yeah. So we're getting quite a few off-label questions coming up. I'll deal with one and then we'll move on from that. So any info on use in renal dialysis or hepatic failure? So one thing I want to be clear is that for Dexcom products, we're not approved for use in chronic kidney disease. So just so you guys are aware of that. Dr. Aleppo probably
I use them.
Okay,
so I
Dr. Aleppo, I'll let you answer that.
Off-label, but I use them in dialysis, and it's interesting because it helps them out, especially the day of dialysis, because there's a lot of switch with the insulin being removed from the dialysate, so it's very helpful. And for hepatic failure, they have a higher risk of hypoglycemia because they have no glycogen, so glucagon doesn't work. It's a very good tool to use. So I use it off-label, but the patients love it, so why wouldn't I do that? Sorry, no guys who can't.
Nope, you're the doctor. I'll leave it with this last one, and I'll use this last one as a plug for the booth. So when will Dexcom be compatible with iPhone? And they just put XX. So our compatibility matrix with all of our different phones and different smart devices and so forth constantly changes. You can visit the website and you can see the updates there. Just stop by the booth. We have a list of that, different compatibilities with different phones. But one of the things we want to make sure is that that signal stays strong and stays good with the different Android and iPhone versions. So we always make sure we're selecting the best with the Bluetooth connection there. So we want to make sure it's a strong, robust signal so that we have good capture of all readings. But with that, again, I want to thank everybody for coming today and for your attention, and enjoy the rest of your conference. So thank you.